Good afternoon, and welcome to today's Fireside Chat, What It Means to Be Immune. I'm Dr. Wayne Teris, Care Compass Network's Chief Medical Officer, and I will be moderating today's session. Care Compass Network is a not-for-profit, community-led organization. While we do not provide direct patient care, we do specialize in supporting the development of high-quality care that results in better health and well-being for community residents. In our efforts to support the development of high-quality integrated networks of care, we work with over 160 healthcare and non-healthcare community agencies throughout a 9-county region of the southern tier of New York. These include hospital systems, community-based organizations, skilled nursing facilities, behavioral health and substance use disorder programs, social services agencies, higher education institutions, and very importantly, community members like you. We felt it was important to address questions and concerns that have been submitted by community members regarding COVID-19 vaccines and immunity, and today's chat will feature panelists from our North region, which includes Cortland, Tompkins, and Schuyler counties. So let's meet today's panelists. Douglas Rahner, MD, is Chief Medical Officer of Family Health Network of Central New York. He is also Clinical Assistant Professor of Family Medicine at Upstate Medical University. Doug has been on boards and advisory committees of a number of healthcare organizations, including the Cortland County Board of Health, Cortland Regional Medical Center, Care Compass Network, and the New York State Health Foundation. He has presented on health topics and health delivery innovation at statewide and national conferences. In 2015, he was named the New York State Rural Health Practitioner of the Year. He is a graduate of the University of Cincinnati College of Medicine and completed his family medicine residency at St. Joseph's Hospital in Syracuse. In his spare time, he likes to bike, swim, hike, and sing in the church choir. Dr. Justine Waldman is board certified in addiction medicine, emergency medicine, and is a fellow of the American College of Emergency Physicians. For 15 years, she practiced emergency medicine primarily in Ithaca, New York. Her interest in medicine has always been driven by access to care and health equity issues. In 2005, she spearheaded the opening of the Ithaca Free Clinic, a volunteer multidisciplinary clinic open to the uninsured. In 2014, she was part of the harm reduction team that gave recommendations for the Ithaca Plan, a public health and safety approach to drugs and drug policy. Since her involvement on that team, she has focused most of her work on health equity. In December 2016, she began providing medical services at the first health hub at a syringe exchange program in New York State at the Southern Tier AIDS program in Ithaca. At the health hub, Dr. Waldman provides low threshold medication-assisted therapy, hepatitis C treatment, and acute care to people who use drugs. She is currently the CEO of Reach Medical in Ithaca, New York, a medical practice offering integrated primary care and low threshold harm reduction services for people who tend to face stigma in the current medical system. Reach Medical offers full primary care, medication-assisted therapy with buprenorphine, hepatitis C screening, and treatment and medical cannabis. Reach Medical is a tax-exempt PLLC under the REACH Project, a nonprofit providing respectful, equitable access to compassionate health. So during the panel discussion, we will be answering a number of questions already submitted by members of the community. In addition, as attendees, you can submit questions in the Q&A on the Zoom webinar or in the comments on the Facebook live feed, and we will do our best to address these questions as time permits. So that being said, we're going to start the discussion. And Dr. Rahner, I'll start with you. And one question we hear quite a bit and one concern that people have is, was the vaccine rushed? You know, Operation Warp Speed. So was the vaccine development rushed? Was it adequately tested? Can you elaborate on that a little bit?
There, I'm unmuted. Rushed is an interesting word, and it depends on how you define rushed. There's no question that the COVID vaccines were brought to market and into the arms of people in record time. And there are a couple reasons why that occurred. One is that a lot of bureaucratic red tape and typical practices that had been the norm previously were done away with. However, the clinical side of this, where these vaccines were very quickly developed, and then they went through a 3-phase testing process. That is the same testing process that all vaccines go through, a phase 1, 2, and 3. Phase 1, you're starting with a small number of healthy individuals. Phase 2, you're starting with a larger group with a more diverse population. In phase 3, typically you're testing vaccines on tens of thousands. In this case, vaccines, all 3 of the vaccines available in the US were tested on at least 30,000 people. And it was a double-blinded situation where you did not know if you were getting the vaccine or a placebo. And so that part of that, none of that was rushed in terms of cutting corners or just going with it well, this seems good enough. This really followed what was standard of practice for all other vaccine development. They were able to recruit volunteers much more quickly in this circumstance than in previous vaccine development. And really the vaccines became available within a matter of almost weeks based on the new technology that was employed, particularly for the messenger RNA vaccines. So in the phase 3 trial, they monitored people for at least 2 months after they were fully vaccinated, looking for side effects. Typically, when you see side effects, they occur in the first 2 months. And that's the data that was used for eventually granting the authorization.
And that sort of leads to another question. And people are concerned and they've asked the question, well, these are experimental. And, we hear the term emergency use authorization as opposed to full approval. And are you able to speak at all to, the nuances or the differences? And I guess I'd like to emphasize that emergency use authorization does not equal experimental.
No. Experimental would imply that we don't know what's going to happen if you get vaccine, okay? That is certainly not the case in that, as I stated before, all of the vaccines went through 3-phased testing periods with a lot of data being collected. And the authorization came about because we're in a health emergency. And if you're in a health emergency, the FDA is allowed to grant this authorization much more quickly than a full approval would be. However, the data that they looked at was very similar in terms of scope and amount that they would look at if they were doing an actual full approval of a vaccine. Since the Pfizer and the Moderna vaccines have been granted the emergency use authorization, both companies are applying for full approval with the FDA. That's a bit of a longer process. They take a little longer looking at that. I do want to say that when the FDA looks at vaccines and what they're doing, it's a much more thorough process than, say, our cousins across the pond in the UK. They actually look at the raw data that was collected during the trials, not just at the conclusions that were made by the drug companies. And they actually did visits to where the labs were done, where the vaccines were going to be produced. It's a very comprehensive evaluation, and that's prior to the emergency use authorization. Since those vaccines have been put out there and are going into people's arms, we've collected a lot more data on all 3 of the vaccines. And some of that data has shown how effective they are, particularly against different variants, and also have shown what side effects were kind of uncovered along the way. Now that instead of injecting 30,000 people with a needle. We've had 300 million people, at least 300 million doses being given. So it's an ongoing evaluation process too.
Did the same thing. There are some vaccines that folks are more familiar with: influenza vaccine, flu vaccine. What's different about this? What is in this vaccine as opposed? Is it the same as the flu vaccine? Is it different? Is there a different method by which these work?
Wow. I'm going to speak to the really two unique vaccines. That's the Pfizer and the Moderna vaccines. They're using a new technology, at least for vaccines, although messenger RNA technology has been around for at least 10 years. Here's what they did. They took, this goes back to high school biology, so bear with me, okay? They took messenger RNA, and this RNA contains the genetic code for what is called the spike protein on the coronavirus. And that's kind of the business end of the virus. That's the part of the virus that connects up to a cell. And so that was put into a mixture of fat, so to kind of encased it in fat, which allows it, once it's in the body, to cross into a cell. Once it's in the cell, it uses the cell's own apparatus to produce that protein. And then that protein shows up on the cell membrane, just hanging out there. And then the immune system sees that, recognizes that, and then goes through that process, which is actually quite complex, to develop immunity to that protein. The messenger RNA itself does not go into the cell's nucleus. It cannot alter our DNA. It doesn't have that power. And it's actually, once it's in the cell, it's degraded in a matter of hours. So it's very, very sophisticated, very targeted, but it produces that piece of protein that our immune system will respond to. Flu vaccine is quite, in many ways, crude. That technology has been around for about 70 years. And what's done is that they will take the flu strains that seem to be prevalent in the world that year. They will grow those flu strains in egg material. And so they'll have multiple copies of that flu virus. And then that flu virus typically is killed. And then it's purified and then created into a vaccine. So it's basically killed virus, okay? And that's what's injected when you get the flu vaccine. Whereas for the COVID vaccines, the messenger RNA vaccines, that is really very targeted, looking at a single protein that is really critical to the function of the coronavirus. The Johnson & Johnson vaccine is somewhat different technology. That technology was proven when the Ebola vaccine was developed a number of years ago. There you have a protein from the coronavirus attached to a cold virus called adenovirus. And that cold virus is weakened, so it actually can't give you a cold. And with that, it's put into the body. The virus infects a cell, quote unquote. And then because of that, it creates this protein again, making that protein available for the immune system to recognize and then develop immunity to it. So, so the technology that's being employed today with these vaccines is really very different and much more advanced than what's been used for flu vaccines and a lot of other vaccines that we have been come to use.
Yeah, and I think that answers a concern that many have had about the inability of it to alter your DNA. It doesn't go into the nucleus. It doesn't, there's a specific enzyme, reverse transcriptase, that's necessary for this to happen. It does not have that in it. So no, it does not alter your DNA. Dr. Waldman, you know, people ask about immunity and what does immunity mean? And some people say, well, gosh, I've heard of people getting vaccinated, but they still got COVID-19. And well, how can that happen? And why should I bother getting vaccinated? Are you able to on what immunity is? And I think you're still muted.
Still muted. Just joining the gang. It's a great question. I think all of us have that same question sometimes with flu vaccines. But in general, this is an amazing vaccine because we have over a 90% immunity rate with it. So there's always these little semantic sort of issues. So someone could have gotten the first dose of vaccine, depending on if it's a 2-dose vaccine, been exposed to coronavirus, and then still gotten, they would have still some protection after that first vaccine, but they still could get exposed, and at that point get the virus. And at each layer of immunity, there's less risk that you're going to get the virus, but no vaccine is 100%. The great thing is that anybody who's gotten, if someone does get COVID virus after, or COVID after being fully vaccinated, which is 2 weeks after the last shot. So for Johnson & Johnson, it would just be the 1 shot and then 2 weeks later, but for either the Pfizer or Moderna, it would be 2 weeks after the last shot. That there's a 90% chance that they won't get the virus. If they do get the virus, and it's going to be very likely that it's a very, very mild illness. And really that's what we're looking for, right? We're looking to decrease the harm that's caused by COVID. We're looking to eliminate the harm, decrease it, do whatever we can. There really isn't any one step when we're talking about COVID that's going to eliminate it completely, but this is the best tool in our tool chest that we have right now. And then when we look at the new viruses, the new variants that are coming out, like the Delta variant, all of the studies are showing that the vaccines are effective against those variants. And so it's just super important that everyone get vaccinated, because we're seeing rises in other states where the people haven't been getting vaccinated. So I think it's probably the smartest thing anybody can do.
Yeah, and I think that brings up a great point, and that is the spread of the variant. And I've seen recently where in states where there are low vaccination rates, that the physicians are saying just about 100% of the people in the hospital are those that are unvaccinated, and those that get very sick are unvaccinated. So, the answer to the question is yes, as you said, it's not 100%. If you get it, it's going to be a mild case. And the other thing is that it really does not transmit to others very readily. And
yes.
So it is important, and it's important to get both vaccines too, because it's been shown that there's much more effectiveness against the variants with the 2 vaccine regimen.
Yes, of course. That's very true.
The other thing, a lot of folks that have hesitancy about vaccines in general, and in particular this one, there's a system called the VAERS, the Vaccine Reporting System for the CDC, and they'll say, pull that up and look at all the stuff this vaccine causes. They're lying to us. They're not telling us everything that's happening here. But I think there are some nuances to this that people are not aware of. And maybe, if you could speak a little bit to that reporting system and why a lot may show up in that system that we don't necessarily hear about later.
Well, I think that what's great about that system is it allows for, this really marks a time in history. So basically what we are able to do with with the technology we have now is have anyone report any symptom that they have. And it's often likely that symptom isn't even related to the vaccine, but it allows us to search for different clues that say, oh, wait a minute, there were 30 people that all felt like their left eye was red. Is there something that's behind the fact that 30 people had their left eye red? And it just really allows for great data to come in and be able to report back out whether there is something amiss with any of the vaccines. The thing that's important to remember is how many people have received vaccine and how there really haven't been enough risk based on vaccine outcomes that may not be positive versus the benefit of getting the vaccine. And there really isn't anything that you can do in the world medically that doesn't have some element, like a tiny element of risk, but you're looking at the risk of getting COVID versus, and giving it to your family and your friends versus the risk of a very, very small risk of having a small effect from the vaccine.
So there are other questions we hear, and Dr. Rahner, you know, I've heard the question, can the vaccine give me COVID? I'm afraid if I take this, I'm going to get COVID from it, because I have friends that got the flu shot and got the flu. So first of all, they're two different vaccines, but maybe you can address that concern a little bit.
Okay, so as I talked about the technology behind the 3 vaccines that we're currently using in this country, the messenger RNA and then the adenovirus. In all those circumstances, what's going into your body is not actual COVID virus. It is a piece, either a piece of the virus or actually a messenger RNA that codes for a piece of the virus. And that one piece cannot give you COVID by itself. You need the actual whole viral particle in order to get COVID. So since you're not getting that whole virus, you're not going to get COVID from it. Okay. Now, you might get some side effects, and we can talk about that. And you might feel, you know, something that, oh boy, this feels like COVID. It's not COVID. It's something else going on, and we can talk about that. Maybe at another question point. So.
We've determined that it can't give you COVID.
Yes.
And we've determined that it doesn't stay in your system for a long time. But, you know, the question comes up, what is the long-term safety of this thing? I know you sort of addressed that, but people are concerned because they feel like maybe it was rushed, but we addressed that. But they are concerned about long-term safety because it's only really been around to any extent since December, other than the clinical trials. So how would you respond to somebody that is concerned about that?
Okay. In this situation, you're trying to predict what's going to happen in the future. Right now, the first participants who were given the vaccine during the phase 3 trials, that occurred in the fall. And so at the most, we have about 9 months worth of data looking at potential side effects. So it's getting longish, but probably not long-term in most people's eyes as far as, well, what happens to you long-term if you get this vaccine. It's difficult to predict the future. However, when we've looked at every other vaccine that's come into existence, that's been developed, the side effects occur typically within the first few months after immunization, okay, after it goes into your arm. And so we now have probably 8 or 9 months worth of data, and we continue to get more data. And so far, we've identified a few issues, and that sometimes is specific to one vaccine or another. And we'll talk about those issues later on in our discussion. So it seems very unlikely that there will be long-term side effects other than things that have already been identified based on loads and loads of prior experience. Okay.
Yeah. So, Dr. Waldman, we did allude to side effects. I know a lot of people are hesitant to get the vaccine because they've heard of the side effects that people can get, particularly after the second dose. Can you speak to, you know, what are some of the anticipated side effects that one may experience after the vaccine, and what does it mean? And, you know, if people have side effects after the first vaccine, should they get the second one? So are you able to speak to that?
Sure, I could speak to the classic ones are pain, redness, and swelling in the arm. And I know for myself, I think I experienced that more with the first than with the second. And with the, then in terms of your body, there is a classic sort of feeling tired, having a headache, muscle pains, chills, fevers, and nausea. I think sometimes it's like fun to talk anecdotally, but in general, for me, I was a little bit happy after my second one because I like got to go, oh, I'm really tired. I'm not going to be able to cook dinner tonight. I'm going to have to watch a little TV and take care of myself. That was the extent. I really thought it was going to be awful, but they were very, very mild symptoms. And actually everyone in my sort of sphere, which is actually a little bit large, also had mild symptoms. But I do think people can tend to have, like a fever or chills that last for that 24 hours after the second one. I know that a lot of people will plan on taking that day off from work, but in general, the symptoms are not extremely dramatic. And again, much better, of course, than getting COVID. And I don't know if I missed another part of the question, Wayne, did I?
Nope, that was pretty much it. But I guess I'll expand on that a little. Would there be a reason not to get the vaccine other than, fear of having a sore arm and a headache and feeling feverish for a day? Are there reasons why one would not want to get the vaccine?
Well, and there is, we did have one person in our office that did have an allergic reaction, just one person, and she ended up calling, I think doing the VAERS reporting and then talking with her provider, and then who consulted with our ID provider locally, and they said, probably you shouldn't get the second one because this allergic reaction seemed a little bit big. But and then in general, what's interesting is it depends on the real only reason not to get the vaccine is if you're allergic to substances in the vaccines themselves. So the two mRNA vaccines, the Pfizer and the Moderna, there's an ingredient called PEG. And if somebody happens to know they're allergic to that, that would be a reason to consult with your provider before going and getting the vaccine. And the other one is polysorbate, which is in the Johnson & Johnson vaccine. So basically, if you're allergic to polysorbate, you're going to want to get the Moderna or the Pfizer. And if you're allergic to PEG, you're going to want to get the Johnson vaccine. If you have a severe allergic reaction to vaccines or injectable medications, you might want to talk with your health provider. And there's always more information that can be found. But I think the best, just that those two allergic reactions are really the only known reasons that I could find that someone wouldn't want to get the vaccine, or would want to switch up the vaccines. I should say they should still get it, but just switch it up.
So can I jump in here on the side effect issue?
Sure.
Absolutely.
So my wife got COVID, and she had a raging fever for about 8 days, 101, 102, felt awful. Everything hurt. She was asking for, you're a doctor, can you get me some narcotics, et cetera. It's just really terrible. And so she felt awful. Afterwards, she received both doses of the vaccine. After the second dose, she had a reaction and felt awful too, but it was not nearly as bad as having COVID, and it only lasted for about a day. All right. And I will say that after COVID, she continues to have a lingering fatigue that is plaguing her. So that's the one thing we talk about. Are there long-term side effects for the vaccine? Well, doesn't seem to be too bad. There are certainly long-term effects from getting COVID itself, even if you even have mild disease, quote unquote. Okay, so.
And I know there's one symptom that's been reported quite a bit that's not felt to be a true allergic reaction. That is, some individuals get a fairly large red circular area on their arm at the site a day or two after, and it can almost look like a cellulitis or a skin infection, more in elderly women. But this is not a true allergic reaction per se. So I guess the caveat is for the attendees out there, talk to your physician, talk to your healthcare provider if you have concerns. It's really a one-on-one conversation. And Dr. Rahner, the question comes up a lot. And you alluded to this, but I've had COVID. Do I need the vaccine? Should I get it? I mean, I'm immune, right? Can you elaborate on that a little bit?
Okay. As we looked at, the millions of people who have had COVID and then looked at their immune response to it, the immunity after an infection is somewhat variable, and it's variable depending on, one, your physical state at the time of infection, two, how severe your infection was. And so having gotten COVID, it appears that there's not a complete constant immunity afterwards. Whereas for the vaccines, it's a pretty consistent, yes, you'll be quite immunized and it will be long lasting. And so right now, the guidance is that if you've had COVID, that immunity may wane over time. You can't count on it being always there. And there have been cases of reinfections of COVID. So if you get vaccinated, it's much more likely that you will have long-term immunity that will be protective against further infection. So that's why we had that recommendation.
Yeah, and I know I've seen studies that actually the ones that are most immune are those that recovered from COVID and were subsequently immunized, and they have the highest level of what we call neutralizing antibody. So if you've recovered from COVID, please go get the immunization, and you'll actually be more immune than most. So
yes,
so I think that's wise. So Dr. Waldman, there's many concerns people have, and a lot that's been out there in social media. And one of those concerns is infertility. And there have been questions raised about that. Are you able to elaborate on that at all? Do these vaccines cause infertility?
I love this question because I didn't know about this. And then, when you Google, you find out a lot. But actually, that comes from where that came from, that I can tell that where that concern came from is someone reported it, but it was based on this idea that if you can get, so it really is based on a concern for males having decreased fertility after getting fevers, and the idea being that with getting the vaccine, you might get a fever, and then if a male gets a fever, then they might have, for a short term, decreased rate of sperm production. But it doesn't, first of all, that hasn't, basically, if you get COVID, you're going to get more likely to get a fever that's much more long lasting, that's going to have an effect on sperm production than the possibility of a 24-hour fever that you might get with a COVID vaccine. But this was really all sort of based erroneously on a report that vaccines can cause people to get fevers, but that doesn't really go along with what the chances are that if you get COVID, that you're going to get a high, long-lasting fever, along with maybe long-lasting effects otherwise. So that's where I learned that came about. I don't know if you guys found any other information around infertility and the vaccine, but I was kind of fascinated to find out where it came from.
No, I think that pretty much sums it up. So I think we can allay folks' anxiety about that. And the other issue is, of course, now certain vaccines are approved down to age 12, and adolescents and young people are getting it. And there have been some reported things that have happened. Is this vaccine safe in adolescents? And, do we think it's going to be safe in children under 12? But, I know that, the school year's over, but we have school coming in the fall. The variants will be out there. How important is it for us to get younger people immunized? And do we think it's safe? And I'll throw that one out there.
I think it's safe. I know that there have been some increased reports of heart conditions in adolescents, but again, the benefits of getting the vaccine outweigh the risks. There's usually a recovery that happens after one of these itises, which is more of an inflammation around the heart. These usually recover. And again, getting COVID is a risk for getting one of these itises, also a myocarditis or a pericarditis. So, basically what you want to do is reduce the risk that your child gets either of these. And by getting vaccinated, that's how we can kind of get on top of this virus. And in general, the school setting is difficult because, what I saw just locally about the school setting was less about terrible outcomes happening because of school, but more terrible disruptions to people's lives from kids being in school who are unvaccinated, if that makes any sense. So unvaccinated kids in school, there's a COVID case and all the kids from that classroom get sent home from school. This has a tremendous effect on all of our lives. So I know that's not as important as the other effect, which is there's so many reasons for us to get the vaccines for our young people, because if all the kids go back to school vaccinated, the restrictions on them are going to be so much less. There's going to be less disruption in our lives, and all the kids are going to be healthy, as opposed to this other way around, which we've just gone through for the last 15 months, which, is really traumatic and I think kind of devastating, especially on single parent homes where you're trying to, or you work 2 jobs and you're a single parent. It's almost impossible to manage the system as it goes right now.
Yeah. I'll just,
sorry to bring up that side, but that to me is
Yeah.
like the bigger side. As a mom, it's like one of the biggest sides that
Right.
we're always talking about is disruptions in our lives because of COVID.
Yeah. I just want to throw out that, when we talk about the inflammation around the heart through myocarditis or pericarditis, these are really rare events. If you look at the data, it's only about 3 out of every 1 million people in that age group, which are typically young males. So that's a really small number of people. So your chance of this happening to you, if you happen to be in that group, is still really, really small. So don't blow it out of proportion.
Yeah, and I know, the consultants to the CDC were going to have an emergency meeting last Friday to really look at this in depth. They're really thinking it's still the benefit far outweighs the risk. But then last Friday turned into an unexpected holiday. So I think the meeting is actually going to be this week where they will look at that in depth. The other question that's raised is, okay, I'll get this vaccine and I'll take both of them, but now am I going to need a booster? I mean, how long does this protection really last with this thing? And I'm not real anxious to get it again. Has there been information out there in this regard? Are we thinking maybe a booster will be necessary down the road?
This is the hot question amongst the real experts as far as will there be a need for a booster. I know that the vaccine companies are kind of gearing themselves up for potentially needing to supply a booster, but the data is still not there whether that's going to be actually necessary. So far, everything that we've looked at in terms of data is indicating that the immunity is long lasting and consistent and protective. There may be a point somewhere down the line where we start to see immunity wane, but that you have to wait time. You can't predict that into the future until you have enough time and you actually see the numbers start to go down in terms of neutralizing antibodies. So for now, I got my vaccine 6 months ago, and I'm still good. I'm not looking for any booster right now, so we're good. Okay, talk to me in 6 months.
I do have a question that came in live, and it sort of elaborates on our comments in regard to influenza and COVID. And the individual said that they had read that if someone had H1N1 flu, that they may have antibodies to COVID-19. Is there any data on that? And I think, if anybody has a comment on that, but I think we already kind of determined that, influenza is a completely different issue, and that would be unlikely. I haven't seen specific data. I don't know if
I have not.
No.
So I can't comment on that. I haven't seen anything.
I don't think we would expect that. I don't think we would expect they would have antibodies to COVID based on the science that we know.
Yeah, they're quite different viruses.
Yeah. There's another issue, Dr. Waldman, maybe you want to address that. A lot of women have issues in regards to if they're pregnant or if they're breastfeeding. Is it safe? should they take the vaccine? I know there's been a lot of discussion around that. Any insights on that issue?
What we know so far is that 80,000 women have been studied, who have been vaccinated, and more than 4,000 of them are being monitored. And the rate of adverse effects for pregnant women is not higher than the rest of the population. Although the opposite is true, if pregnant women get COVID, they are at a risk for severe illness. So basically, I think the risk of the vaccine or the risk of COVID far outweighs the risk of getting the vaccine. And in terms of breastfeeding, there's no data on the safety, although the effects of that mRNA that Doug was talking about, the thought is that would have no effect on the breast milk. So mRNA vaccines are not thought to be a risk to breastfeeding infants. And, you know, I guess, and this would probably be a leap, and I'll take Doug's thoughts on this, but I feel like part of the best thing about breastfeeding was as I'm breastfeeding, I'm giving passive immunity to my fetus. So I would want to breastfeed after I got the vaccine, just to make sure that I continue to protect my neonate or my infant. And I don't know that I think I had like healthy kids because I breastfed both of them for a year and a half, as long as they would do it, actually. So yeah. I don't think they've done studies on that, but I think that the passive immunity would be super important.
Yeah, it does. The antibodies from the vaccine do one pass through the placenta, and so if you have an unborn child in the womb, that child is getting antibody to the COVID virus, and then it is also found in breast milk. So you're obviously, these infants are too young to be vaccinated, but you are providing protection. So by doing it that way.
One other question that's been asked, if somebody's vaccinated and then they get a mild case, let's say, or an asymptomatic case, do they still carry a risk for long COVID or longer term problems? Any data on that at all?
I couldn't find too much on this, except that basically, and Doug, maybe you know more than I do, but when we talk about this long-term virus, and I think Doug has some direct experience with it, this is where people have symptoms that we talked about, like fatigue for more than 4 weeks after being infected. They're looking to find, I think basically what most people are saying is that if you get vaccinated, you're less likely to get this long-term COVID because you're less likely to be symptomatic in the first place. So I think but I don't think there have been direct studies looking at if you can get long-term COVID after being vaccinated.
Yeah, I haven't seen any studies or data on that. So there may be out there, but I haven't seen them. But I suspect they're not out there yet.
And some folks have asked, what do we think is the best practice in terms of masking and social distancing once we're fully vaccinated? Any thoughts?
So I think that what I understand are the best is, in places that are less than 10 people or so and everyone is vaccinated, I feel pretty comfortable. No one has symptoms. I think basically with family and friends that I know are all vaccinated, then I won't wear a mask. If I'm outside jogging, I also won't wear a mask. If I'm outside at a picnic, if it's a very large picnic, I still think the rates are low of transmission, but I probably would wear a mask. So I think it really depends on the setting. I don't know if for either of the two of you, you would do anything differently than that.
I'll just say that the one place where I definitely would wear a mask if I was in a large group indoors.
Absolutely.
Okay, which carries the highest risk in any case, whether you're vaccinated or not. And again, since no vaccine is 100%, I'd rather not get COVID. So even if it's a mild case. So
I think a lot of it is, how much everybody every day manages risk. And let's say I had a family member who was immune compromised, a child with cancer, and I was in, close proximity to them, and I was fully immunized, but they have not been able to be immunized yet. I think I would still be in that situation more prone to wear a mask and be more careful, because nothing's 100%. Everything is a risk benefit analysis. So I think, just some common sense really is the trick.
I back up there, just another great effect. I've been like, oh my gosh, this is great. I don't have to wear a mask everywhere. My partner's like, I'm going to wear my mask because I didn't get flu. No one got sick this year. We should all just continue wearing masks because we really kept the illness rate down. Like it's just a great way out in public to keep your rate of illness down.
Yep. I for myself, probably not now, but when cold and flu season shows up again in October, November, I'm probably going to be wearing a mask in certain settings just because, okay, I'm not so worried about COVID anymore, but there are all sorts of other bugs out there that this seems to be a pretty effective and easy thing to do so I don't get sick. That's it.
And then pass it on to patients or your family.
Oh, yeah,
I mean,
right. Yeah.
Locking down wasn't fun, but it sure was nice to go an entire winter without a cold or the flu. That was pretty awesome.
Right.
Sort of on another topic, and we had a brief discussion prior to the start of the webinar here, but I know that you folks deal with, underserved populations and populations at risk. And I wonder if you might just give us some thoughts on how we manage that and how we help folks that are maybe more underserved, have difficulty getting to a physician, don't understand, or maybe just talk about some of your experiences. I think those on the webinar might be interested in that. I'll just throw that one out there.
Okay. Certainly access always needs to be addressed in terms of whenever you're dealing with populations that have trouble getting healthcare, and that takes a lot of different approaches because everyone's different, and in terms of if you're homeless versus if you're an elderly person who is homebound and you live in an isolated area, those are two different circumstances, but in both circumstances, you have lack of access. And so you have to tailor that to that individual's situation. So it might be making use of some of the services who are people going into the homes to do vaccinations. And then the other thing is to, for those who are really hesitant to get vaccinated, is shaming never works as far as getting people to sort of make that choice to get vaccinated. But what is helpful is listen to people's actual concerns, and everyone's individual concern tends to differ somewhat from person to person. And so you really have to do some listening and then address those issues individually. And that's how you kind of move the needle. So.
I would say that that was the perfect answer. And also just to remember that I think that especially for people of color, there's a healthy distrust of the medical system in the United States based on bad things that we've done, right? And so this is a real opportunity to be transparent about how the vaccine was tested, as Doug went over. What are the benefits, especially for the BIPOC population to getting vaccinated, because this is the population that really had the worst health outcomes. And so, there's that kind of growth, there's a mismatch here, which is I don't trust the vaccine. I'm also a person who's more likely to get sick. And I feel like it's our job as physicians and, to kind of really try hard to bridge that gap. because the distrust deserves to be there based on historical events, and so we can't discount the fact that that there really have been in our history a lot of gross, not well intended studies that had bad effects on people of color.
And I really want to, stress to everybody out there, have a talk with your personal healthcare provider. Certainly, we feel it's important to do things like this and have these public discussions, but in the end, you need to have that trusting relationship with the person that you know and that takes care of you. And I think that would help to allay, a lot of the anxiety. I think we've seen over the course of all this a real shift. We started with mobilization and mass vaccination sites and a lot of difficulty getting these. And now, the demand is reducing, and we're turning a little bit away from the mass vaccination sites, and now a lot of very directed efforts. So Dr. Waldman alluded to, there are really efforts to get out to where people are in their communities. And there are certainly rural areas and underserved communities where people have difficulty. And there are now a lot of pop-up sites occurring, and the governor has actually identified the particular zip codes where there's the most difficulty getting people immunized, and there are specific efforts being made in that regard. And additionally, there's a move now to try and get these immunizations into primary care offices. There is a process, and that really, just for a lot of logistical reasons, did not happen at the onset. So there's a move towards going to the primary care, getting out into the community. Small efforts. I know in Broome County, at least as of a few weeks ago, if you've had 10 people or more that needed the vaccine, you called them and they would create a pod for you. They would come to you. I mean, these are the kinds of things that really need to happen, just one person at a time. So I don't see any more questions in the chat. We'll give folks a minute or two to do that. And I don't know if either panelist has any other final comments or other thoughts or wrapping up comments before we conclude. I think we've covered a lot.
Yes, we did.
Okay. Well, what I'll say here is, so at the beginning of all this, the governor actually created, or New York State created hubs, what we call vaccine hubs, that were responsible for rolling this out. And the Southern Tier Hub, the lead organization is UHS. And if you have questions about where do I go get this vaccine, and if you're computer literate and have access to internet, if you go to southerntiervax.org, so it's southerntiervax, one word, .org, and that will take you to a website. And on that website, there is a lot of good information, and there are actually pictures of each county. And if you click on the county, you'll get a listing of where can I go get the immunization and how do I get there. If you are not more computer literate, don't have access, 211 is a resource where you can call and they can help you. So I'd encourage everybody out there to do that and follow up with your primary care. And I don't see any more questions. So, and I think we've run through all the questions that we received. So thank you to my panelists. Great job. And thanks to everybody out there for attending, and hope you all have a good evening.
Okay.
Good night.
Thank you. Good night.